Can you see my screen?
Yes.
Okay. So yeah, this guy is 60 years male who had history of prostate cancer, and then patient underwent robotic assisted laparoscopic prostatectomy, and the Foley's catheter was out about a week ago, and then patient started developing difficulty passing urine, abdominal pain, and landed into the ED. So in the ED, we had this CT. So the kidneys and the ureters and the bladder. Okay, that's it. I can show you in other sagittal and coronal, but yeah, any thoughts? Just looking on the axial slices. The main finding is in this image, I would say. Yeah, somewhere here.
Yeah, I have some thoughts. It reminds me of a case that Steve had. Gitanjali is saying urethrovaginal fistula, but Gitanjali, I think this patient had a prostatectomy.
Yeah, that's the key.
Yeah, so I think Rupa is saying defect in the urethra. Yeah, exactly. I think it's a dehiscence of the anastomosis between the bladder and the membranous urethra.
Yeah, that's right, Doc. So yeah, in this, we can see the bladder is hugely distended, and here we can see the defect posteriorly between the bladder and then the prostatic urethra. So there is this collection outpouching. So this is extraperitoneal collection of the urine. And I think that's also resulting into, like this whole thing is resulting into bilateral hydronephrosis as well, that we could see hydroureteronephrosis to be exact. Yeah. So this is one of the not common but important complications of the robotic assisted laparoscopic prostatectomy. Yeah, and it could be intraperitoneal, extraperitoneal. So here in our case, it is mainly extraperitoneal. And since this is pretty huge, so we can evaluate in regular CT. But if it is very small, then we might need CT cystogram. I think they usually manage it conservatively. But if not, then probably they will again have to do some kind of repair. Yeah, I think that's it from me, Doc.
Yeah, that's a great case. It's especially the sagittal is really nice. I think Steve Eberhardt showed a case similar to this, and we had a discussion about how, we're seeing these more and more, these kind of like the collection in the prostate bed, but because they're contained there in a kind of like collected space, a lot of times they're treating them conservatively, like you said, and not necessarily going back to repair it because it's a very difficult surgery to do.
You got a good memory for that. I remember that case.
Yeah, because I had one similar too, and you said yours, they treated it with a Foley and then it was still contained, and then they decided to just kind of treat it as an extension of the bladder. In this case, because it's causing the hydro, I wonder if there's also like a stricture below it that caused it to kind of outpouch like this and cause the hydro, because it seems
perhaps so, because the bladder looks so full.
Yeah.
Like, why are we not voiding properly here?
Yeah. I think that later in the ED, they were able to place a Curious catheter, and then the urine was drained almost 2 liters, and the patient felt better. But yeah, we don't have anything after that. But yeah, that's, I think, good point. Maybe there is some stricture in that area somewhere here.
Great, thank you.
Thank you, Doc.
Victoria, do you want to go? Okay, I'm not hearing Victoria, so I'm going.
I'm sorry. I thought, but go ahead. You want to go first? It's whatever you prefer.
No, you go.
Okay. Advanced portion of the screen. Okay. Can you see it?
We do.
Okay. So, I figured I'll stick to things I know best, which is liver. So we'll start with this case. Patient is cirrhotic, and this was about last spring situation, and there was a lesion, about 1.2 centimeter. And so if you were to use LIRADS, like what do you think you would give as a category?
It looks like rim enhancement, not non-rim enhancement.
Right. So
Yeah, like
okay.
Gitanjali is saying LRM because of the rim enhancement, and Rupa is asking if this is an EVIS scan too.
This actually is EVIS, although I'm not showing you EVIS.
I think I'm on board with.
Say it again.
I think I'm on board with it being like a more of a rim enhancing lesion.
So you guys are more astute, but this was read as LIRADS 5. So it was read as, there was no other, this is the EVIS phase. So this was read as a LIRADS 5. You can, and you're right, the rule is if you're trying to figure out if it's rim versus non-rim, you go with rim, right? So appropriate category here would be LIRADS M, but that's not how it was read as LIRADS 5 because it was interpreted as non-rim APHE and washout and everything. So that was read as a LR5, and this patient was a candidate for liver transplantation. So we often just let these patients kind of chug along, and obviously there was COVID situation happening. So the patient came back 6 months later, and this, let me just make sure that no PHI flashes when I switch the. Okay, so this is about 6 months later, and here's the appearance of the lesion now. And you can see, first of all, it grew quite a bit. So it went from 1.2 centimeter to about 3 centimeter. And now there's no doubt that this is a rim arterial face up enhancement. You can see here. So this was at this point, correctly recategorized as LRM. And the patient was, can you hear me?
Yes.
Hello? Okay.
Yeah.
I'm sorry, just the Zoom just flashed something funny in front of my eyes. Anyway, so and again, you can see that the most prominent LRM feature here is rim arterial face hyperenhancement. Everything else kind of doesn't really have the target appearance. Anyway, so this was biopsied, and this is a cholangiocarcinoma. So remember, patients with cirrhosis do have a risk of cholangiocarcinoma. Of course, HCC is far more likely to develop in patients with cirrhosis, but they're also at higher risk of non-HCC malignancies. And just as a kind of counterpart to this case, one of the things that I've seen is that LRM lesions tend to, or non-HCC malignancies, tend to grow much faster. So this lesion went from 1 centimeter to 3 centimeters in 6 months, which, not to say that HCCs cannot possibly grow this fast, but they tend not to. They tend to grow a little bit slower than this. And so this is an example of a patient, so this is a patient who has history of cirrhosis and lymphoma. And this is a scan from August. And you can see that, patient really couldn't hold their breath very well, but you can see even in arterial phase with all the motion, you can see these blobs of brightness there, and these blobs of brightness wash out, and they're true lesions. You can see washout here, you can see washout here, you can see washout here, there, and there. So these were all, there were 5 LIRADS 5 lesions, and because, the patient had lymphoma, they weren't sure, if they can just trust the imaging appearance. So the patient had a biopsy. one of these lesions was biopsied and it was confirmed to be HCC. And then of course, COVID surges. So then again, patient's delayed in care and comes back. So this is in August, so comes back in January, so just about 6 months. And notice that in these 6 months, these 5 HCCs really didn't change much in terms of size. So again, obviously nothing is 100%, always follows the rules, but in general, non-HCC malignancies do tend to grow, a little bit slower than non-HCC malignancies do tend to grow faster than HCCs do. So for example, here you can see this lesion stayed the same if we look at the same phase. So anyway, so this is two kind of interesting points about this case, that even though patient had primary malignancy once, in patients with cirrhosis, Lyre's 5 criteria quite specific for HCC. All right, the next case, interesting cases, is a young man. He's is 40, and he has he's alcoholic, but doesn't have a known cirrhosis. An interesting case here is that he went for a routine physical to a primary care physician who examined him, and the physician assessed that the patient had quite a big of a liver. So assessed hepatomegaly and sent the patient for ultrasound, which I don't have. This was an outside institution. So then patient, based on ultrasound, had an MR. So you can see that, you can see that, the patient is quite thin, which makes the palpation of the liver, I guess, easier. But still, you can see that the right hepatic core is pretty much replaced by this huge mass, and the 3 additional smaller masses more superiorly. This is the T1 pre. You can see the largest mass is quite heterogeneous on T2 and primarily bright on T1. These are the masses posteriorly, and then when we give arterial, we'll give contrast of the arterial phase. You can see that you have like these vessels coursing through the parenchyma of the solid masses, and the large mass is primarily hemorrhagic. You can see on the portal venous phase, there's washout in these 3 smaller masses, and again, the larger mass is primarily hemorrhagic. And we confirmed that on subtraction. You can see that this is on the periphery, you can see nodular kind of remaining solid tissue, but the bulk of the mass is not. So this is a non-cirrhotic alcoholic patient, 40, just incidentally found to have some abnormality in the liver on a physical exam. So any thoughts? Or I can just go through.
This is pretty crazy looking.
Right.
That large one was reminding me of I don't know, a MCN kind of, the cysticky parts, but it looks like, and the nodular enhancements, like it's not just a complex cyst. Rupa is asking about a hepatoblastoma.
Okay, in the 40-year-old?
Little old.
Yeah.
And then the other ones, you said they were washing out. Were they arterially enhancing also?
So you can see that, you see these lines. So once you see vessels, arteries in the mass, that's considered, arterial phase hyperenhancement. That's one of the ways arterial. So these are hypervascular. This is a little bit too early of phase as well. So they are hypervascular. See that? So right. So it's multiple masses, and the largest mass is hemorrhagic. So obviously the differential is broad, and all the things that people are putting in are fair. Patient does have alcoholic disease, so and these are hypervascular masses with blood. So HCC also is thrown into differential. So we recommended the biopsy, and they biopsied one of these masses, and it came back as neuroendocrine tumor metastases. So a couple teaching points here. Well, one is obvious that things like this usually needs biopsy. But this is an example of how, without cirrhosis, the Leyert's 5 criteria lose their specificity, because you do need to have substantial pre-test probability to maintain that high post-test probability. So this patient, even though he's an alcoholic, he doesn't have cirrhosis, so he's obviously is allowed to have many other entities aside from HCC. And in this case, he had neuroendocrine tumor metastasis. We still have not found the primary. They did a PET, and so far they couldn't find the primary. Moving on.
Just a question. So the biopsy was done from the big mass or the smaller masses or both? Because the smaller ones looks like neuroendocrine mets, but the big one looks pretty weird.
It's just hemorrhagic. It just bled into itself.
Oh, okay. Okay, makes sense. Yeah.
Right. So you can. It's all just huge hematoma mass. If you looking carefully at the periphery, the peripheral, these residual areas are. They look very similar to the main masses. So this is just hemorrhagic neuroendocrine. And I guess anything that's hypervascular can bleed, and somehow this he bled. We weren't able to get any history of trauma or anything like that. Somehow he just spent, and he had no pain, nothing. It was just all incidentally found. This is another interesting case. This is a young woman. And she came in with pain. And you can see that the liver is not normal, right? You can see that there's some evidence of kind of nodularity and parenchymal disease. And then you have these just kind of geographic areas of abnormal signal intensity. These are T2-weighted sequences. Here's the common bile duct. You notice these huge intrahepatic, and extrahepatic feeling defects with peripheral biliary dilatation. Notice also the patient has, bibasal consolidations. The spleen is large, and you can see similar kind of like geographic areas of abnormality in the spleen. We give contrast, and you can see that these areas of abnormality in the liver are not enhancing. So any thoughts? And here it is in diffusion.
For the spleen, I was thinking like infarcts of some age maybe, but then you don't get infarcts so much in liver, and I'm not sure if they would look like this if they were.
Right, so these are infarcts. It is very unusual to get infarcts because of the dual liver supply, but this patient is special. Well, she has underlying condition. So she came in with chest pain and abdominal pain. She's young. She's in her late teens, early 20s. I don't remember exactly how old she is, but very young.
Could it be sickle cell?
That's right. She's a sickler. For whatever reason, her spleen didn't auto-infarct yet, so she still has a big spleen with infarctions. So this is infarct related to just sickling of of her blood vessels, and all the tiny venules and sinusoids in the liver get blocked off. So infarcts of the liver are not common, but they can happen. And again, if you look carefully, it makes sense, right? With the capsule enhancement is preserved, and if you forget that this is liver, the appearance looks very, very similar to what we see in a spleen, right? So it just looks very, very similar. So, and then of course she has these huge biliary calculi, as patients with sicklers can develop.
It's a great case.
All right, so this case is irritating because I don't have an answer. But
Got lots of those.
I know, but this is irritating because we've tried every which way to get an answer. So you can see that this was a patient. This is an outside study. Patient came in with just kind of malaise and low-grade fevers and abdominal pain. So nothing specific. And I forget why they got an MR, how they got an MR, but this is how they came into us with this MR and this kind of vague history. And notice that, you know, the patient has two lesions. Both of them look very similar. So this is a larger one. This is a smaller one. Ring enhancing, right? This is the arterial face, maybe a little bit of hyperemia around the small one, unclear. So this was interpreted very appropriately as, you know, could be METs, right? It could be abscesses. Patient has no risk factors for either. So that's what we thought, either METs or abscesses. Recommend a biopsy. So the biopsy was done, and the path came back as, you know, inflammatory changes and staining of this and staining of that. It could represent an inflammatory process, or could just be sampling of parenchyma adjacent to neoplasm. So correlate clinically. So that's the path report. So then we send the patient for the PET, and again we see, you know, that this larger lesion does have ring enhancing, you know, hypermetabolic periphery corresponding to what we see in the MR. And the little one probably is not as well seen. So it was read as, you know, METs versus abscess. So we're still in the same kind of position with this patient. So if anybody has any suggestions of how we can help this patient with diagnosis aside from actually having a liver resection, I would love to have your opinions. So everything we've done so far provided the same differential diagnosis. And his symptoms are such that they can be both with infection and with malignancy.
Sometimes you just have to give things time to declare itself.
Right. I mean, I was hoping, I mean, I'm kind of sort of leaning toward an abscess, primarily because of this hyperemia.
Yep.
But leaning to, you know, it's not specific enough to be totally confident that we're dealing with an abscess. But yeah.
Sometimes, you know, when we've had abscesses that they just do like a full court press with antibiotics, and then we re-image in, you know, 4 to 6 weeks and make sure we were right.
So the time difference between the MR and the PET is, let me calculate, 2 months. 2 months. Can't really see it on contract, but you can see that it hasn't really changed. So I guess that's not very helpful.
And were they treating with antibiotics in between?
I'm trying to see the results. No. They were not treating. You know, the patient didn't get worse, but they also didn't get better. So I don't know what they're going to do. They probably will do resection to get the diagnosis. There was nothing else anywhere in the body on PET or on CT. Anyway, so this is an irritating case of the day. The final case I have is a patient came in. They have a history of colon cancer, and this is just an interesting, unusual thing that in this case, the patient's colon cancer mets did. So you can see, you know, obviously the patient has a bunch of big mets. But what's interesting here is that if you pay attention here, this tumor grew into a bile duct there. So you can see common bile duct, and then it just grew into the right intrahepatic bile duct. So this is very unusual for non-cholangiocarcinomas to do this, but it is, in this case, it did happen. When, rarely HCCs do this, and when they do this, this is a very poor prognostic sign and correlates with, with all kinds of bad, things. So I don't know if that holds the same for mets, but you can see here that the met just kind of goes right into the biliary tree. And you can see it causes a little bit of biliary tree dilatation right there. So it's very unusual. But
I don't recall ever seeing that.
right. So I've seen this with HC, but I don't think I've ever seen this with colon cancer. So, okay, these are my interesting and one irritating case.
Very interesting cases. Can you guys hear me okay? Because there's some kind of lawn work going on in the background. Do you guys hear a lot of background noise
No.
right now? Put my headphones on. You guys can hear me okay?
Yep.
Okay. I'm going to, okay. Can you hear that background noise?
I can. I don't know about the others.
Okay, okay, good.
I can't hear anything but your voice.
Okay, great. So this is just a cute one, and audience participation. What do you guys think about this?
IVC clamp.
Iatrogenic.
Yeah, yeah. Do you know the name of it?
I think it's called IVC clamp.
It's
Yeah, I like.
might have an eponym too.
Yeah, it's called an Adams DeWeese clip, but Victoria, I agree with you. I like just calling it an IVC clamp or clip, but it was actually invented by these two guys, Adams and DeWeese, in the 1960s, and they wrote like a retrospective paper about it in 2011, I think, about how they came up with this. They tested it out on dogs, but basically this was before there were intravascular IVC filters, and they had this kind of serrated clip that they would put on that would allow blood to still go through, but would capture the larger clots. Unfortunately, this clip caused a lot of issues, like in this case, where it basically obliterated the IVC in a lot of patients. It can also, because you're suddenly cutting off IVC return to the heart, it can cause sudden cardiac decompensation. And generally it can cause severe lower extremity edema. So luckily they later invented, intravascular IVC filters. But some patients in the 60s until the 70s were getting these IVC clips. So just so you know that they exist. Okay, I'm going to gingerly try to show an ultrasound without showing patient information. Okay. What do you guys think? This is a renal transplant ultrasound, and this is the waveform in the main renal artery. So what do you guys think about this?
Reverse diastolic flow.
Yep, so reverse diastolic flow, and Rupa is saying RVT, or renal vein thrombosis. Excellent. So we were concerned about that. We saw a lot of reversal of flow in the main renal artery. All the way through, it's reversed, so it looked very alarming. And then this was the grayscale picture of the kidney.
It's a little boggy and heterogeneous.
Uh-huh. Anything else?
Subcapsular fluid.
Yeah.
Yeah, so there's a huge hematoma around this kidney. And so this is the kidney itself. And then this is this perinephric hematoma. So looking closer into the history, they actually had undergone, this was months after renal transplant, and the transplant wasn't working well. And they had undergone a biopsy, and that had led to this large hemorrhage. So we then did a CT, multiphasic CT, and you can see that there was active extravasation, and the patient went to embolization with IR. A couple of other things that I learned about this, they did present with hypertension. And so we were, calling this a page kidney and kind of wondering about the, Rupa saying page kidney, excellent. I'm wondering about page kidney and transplants. And you can actually see that a lot of the hemorrhage was kind of subcapsular and contained around the kidney, but also extending into the retroperitoneum and, extending into the abdomen. So what I read was that renal transplants have a lower rate of getting page kidney because a lot of times they cannot preserve the capsule when they're harvesting the donated kidney, and therefore if there is a subcapsular hemorrhage, it doesn't get trapped as acutely and as severely as in a native kidney. In this case, this transplant kidney looks like it had a mostly intact capsule, which is why the patient was getting hypertension, page kidney. But then at some point, the capsule or either disrupted or had a disruption in it and was able to extend beyond it. And then the other thing that happened in this case was that because their transplant was kind of older, the surgeon said that, the patient has a lot of adhesions. It's not like a hematoma in the immediate transplant setting. So they did not want to go in and immediately evacuate it. So what IR did was actually put a drain into this and instill TPA into the hematoma and lyse the hematoma and try to drain it off. It worked moderately well, but unfortunately this transplant still has not regained function. So it's unfortunate. Perinephric hematoma with, and then with reversal of flow on the ultrasound. Okay, this is my next case. Oh, actually, let me see. I did make a little slide. If I can show you guys. Just a little review. So renal transplant ultrasound, the most common thing we're going to see is elevated RIs in the interlobar vessels, where the RI is approaching 0.8, 0.9. On ultrasound, we can exclude causes of edema or increased resistance in the kidney, like hydronephrosis, a collection pushing on the kidney, renal vein thrombosis. But if we don't identify that on ultrasound, then they may need a biopsy to look for rejection, ATN, drug toxicity, and recurrent disease like IgA nephropathy. Renal vein thrombus, this is more common in the immediate post-operative setting, especially if there's a prolonged cold ischemia time. And that's when you might see this severe increased resistance with this reversal of diastolic flow. And then a later complication usually is renal artery thrombosis. That's usually often due to atherosclerotic disease that creeps from the iliac artery onto the renal artery. And you'll have very high flow at the stenosis, greater than 200 to 300 centimeters per second. And then distal to it, the ischemic kidney will try to vasodilate to get more flow. So you'll see the tarvis partus. So slow upstroke and then prolonged, slow and long upstroke. Okay, this is my next case. This is kind of a crazy one. This is courtesy of my colleague Linton Eberhardt. And curious as to what you guys think about this spleen. This was a mystery case for us. Patient did get a biopsy. So massive splenomegaly up to 25, multiple T2 hypointense masses that kind of showed like delayed enhancement.
Are there any other known underlying medical conditions?
No, they were not known before this. I'll tell you some supplementary material afterwards, but we found out, well, I guess maybe in retrospect, we could have put it together. I don't think we could have put this together at all, but you can see the masses have delayed enhancement. And some relevant labs in retrospect are that the patient is anemic and has a low platelet count.
I think we had a case that was similar to this that turned out to be extramedullary hematopoiesis, but I'm not sure if they looked like this or not.
Yeah, I had a case too where it was in the spleen, and that's a great thought. And especially like if you have myelofibrosis and then extramedullary hematopoiesis in the spleen, Great thought. That wasn't what this was. We Googled a lot and found cases of like literal cell angioma that had, we were thinking, multiple lesions, T2 dark, delayed enhancement, maybe this is literal cell angioma. And we found some cases online where there were lots of cases, lots of lesions, and even moderate sized, like moderately large lesions. So that was kind of our top diagnosis. We thought maybe the spleen just should come out, but it ended up getting biopsied. And our pathologist called this extensive histiocytosis, most consistent with type 1 Gaucher disease.
Boy.
I know. So here's my little slide about Gaucher disease. Oops. So Gaucher disease, just to remind ourselves from medical school, this is, we're lacking the enzyme to break down glucose cerebroside, and it has variable severity. So type 1 is actually the type you get as an adult, and actually these patients can do quite well. But because they can't break down this glucose cerebroside, they develop these Gaucher cells. These are histiocytes. This is what it looks like on pathology, that has excess glucose cerebroside within them. These Gaucher cells then accumulate within the spleen, and you get massive splenomegaly. You can also get hepatomegaly. And 30% of patients will also develop these histiocytic nodules in their spleen. You can also get it in the bone marrow, and this is what causes the anemia and the low platelet count. So our patient did have those things, but we couldn't put it together with this. People are saying, wow, cool, nice case. Yeah, definitely was zebra for us. So the adult form, they can have a long life. And some of the treatment though is if you are having the severe splenomegaly, is you can do enzyme replacement therapy to break down the glucose cerebroside. This is an intravenous therapy. And then there's also an oral therapy called substrate reduction therapy. So these patients can live quite long. This one only presented in this patient in their 60s with increasing abdominal pain and girth. The type 2 Gaucher disease is the infantile type, and this usually leads to death by age 1 to 2. So that was type 1 Gaucher disease. Oops. My next case is this one. This is just kind of a
on that last one. Was biopsy and not splenectomy the right choice, or does it matter?
Yeah, this patient, I mean, what I read was that they don't necessarily need splenectomy. That doesn't really solve the problem. Doing a splenectomy, it could solve the pain. And in this patient, they're opting to just treat them, the hem-onc is just treating them with the enzyme replacement therapy. And so they're not planning to do a splenectomy.
Okay.
I think we were kind of surprised that they decided to do a splenic biopsy, because we were like, shouldn't it just come out? But, I guess it makes sense in this case in that their treatment is not that they're going to take out the spleen. So this was just kind of a dramatic case. This is, you can see this large heterogeneous intracardiac mass that is also involving the IVC. Maybe even extending into a lumbar vein here. And then it kind of ends, but there's kind of modeled enhancement below it in the IVC.
Not renal, so maybe it's a sarcoma of the.
Yeah, exactly. So, and Swachchhanda said it too. So this was an IVC leiomyosarcoma. This ended up getting biopsied transjugularly. And came back fibrosis. So they ended up having to repeat the biopsy. In general, for leiomyosarcomas, you want to go from above because they can have bland thrombus from below. So if you go through a femoral vein approach and go to the bottom of the tumor, you could just biopsy the bland thrombus. But in this case, they ended up getting the diagnosis through an IVC biopsy from below. I don't exactly know what happened to the transjugular biopsy, but from above, it didn't work out. And this is how it looked on MR. And the MR was helpful because, as I said, there was that mottled flow below it. Here on the MR, we can see that evil gray of tumor expanding the IVC, extending into the renal vein, but didn't arise from the kidney. So we really thought it was an IVC leiomyosarcoma. And then we can see that the flow void of the IVC below it is preserved. So there's no kind of bland thrombus below it, and it just goes right into that tumor. Unfortunately, this was too extensive to be resected, so they're just doing chemotherapy. But ones that are, even if it extends a little bit into the heart, we even see that with renal cell carcinoma. If it goes up the IVC into the heart, they can resect it. It often means that they first, and you have a cardiac surgeon open up the heart and resect the part that's in the heart, have a hepatic surgeon there to make sure that the hepatic veins get reconstructed to an IVC that's reconstructed the heart, and then for the renal cell carcinomas, the urologist will then resect the IVC part. And this is my last case. So this was years ago. This was the initial scan, and you can see that their pancreatic duct was dilated. There were some side branches that were dilated. And there's a lot of fluid around the pancreas, and clinically they were having pancreatitis. So at the time we thought this is probably some chronic pancreatitis. There was like all this fibrosis of the gland, fluid around it. Clinically they had pancreatitis. So they treated them for acute on chronic pancreatitis. A couple of years later, they came back and their pancreas looked like this. Yep, Gitanjali is getting to
worry about
chase.
Mixed IPMN.
Yeah, exactly. So now, we still see a lot of pancreatitis, edema, fluid around it, but the duct is really dilated, and that's unusual for chronic pancreatitis, and also to have such a smooth duct, not kind of like a raggedy duct. We don't see calcifications, and then the duct is getting huge over here. And so we brought up IPMN, but it was still kind of clinically, they thought the patient had acute on chronic pancreatitis. So we kept going. A couple of years later, the main duct is still really dilated over here. The pancreatitis is getting worse. And there's now even like edema going into the wall of the stomach here. And this is what it looks like on MR. So now, though, we're very convinced that this duct should not be this engorged. So the patient ended up getting a Whipple, and this was a mixed main duct side branch IPMN with mostly the main duct component. It had a lot of low-grade dysplasia and high-grade dysplasia, but no adenocarcinoma. So lucky for this patient, the margin of where they ended the Whipple did have low-grade dysplasia, and the background pancreas had a lot of chronic pancreatitis. So my teaching point here is that chronic pancreatitis and IPMN sometimes can be mistaken for each other, although if you have engorgement of the duct, a smooth duct, always think about IPMN. And also when you have main duct IPMN, a lot of times you will have also chronic pancreatitis. And that is because the IPMN and all the mucin is blocking the juices, and so it's causing this pancreatitis. So they often kind of are seen together, but don't get fooled into just saying that this is pancreatitis when the underlying issue is the IPMN.
I think I've seen that a couple of times too.
Yeah, and my pathologist was actually telling me that most IPMNs have, especially main duct IPMNs, have chronic pancreatitis in the rest of the gland. And they usually also do a frozen duct, frozen on the margin, and they kind of march until there's no more at least high-grade dysplasia. And then we'll surveillance the gland for the rest of this patient's life. One other interesting point is that there were a lot of lymph nodes here, but these were all negative. So they were all kind of like reactive to the inflammatory process.
Speaking of reactive nodes, while you're on that topic, I had a case that came out of the ED recently where there was axillary nodes that are the type that you would see in the start of lymphoma or possibly breast cancer. But the ultimate clinical diagnosis, not established, was that it was due to COVID vaccines.
Oh, wow.
Reactive, which was in the differential, but I think it's that made the most sense.
Wow, interesting. It looks like Nelly, are you good? Are you sharing your screen?
Yeah. Can I share a case? Are you finished?
Yes, I'm finished. And after you show your case, Ben had a couple that he wanted to show. So
Oh, cool. Okay. If it's okay, can I go first, Ben? I need to return to residency interviews.
Absolutely, Dr. Tan.
Thanks a lot. This is a case that we presented at HCC, and I hadn't seen this before, so I wanted to share this. So there's a liver lesion here. There's the DWI, and on T2, it's like I love Aarti's evil gray descriptor. So what do you guys think? So when I saw this, I was
don't
like,
like
oh,
it.
cholangio. Yeah,
Yeah.
right. It doesn't.
You'd say cholangio, and you could be looking at a met.
Right. I mean, everything just screams badness. This turned out it was biopsied, and it came back as a bile duct adenoma. So I looked it up because this is my first case of a bile duct adenoma. It was biopsy at an outside facility, and then our pathology, we reviewed the slides and confirmed the diagnosis. So it's rare, and it's usually incidentally found. Not common primary liver lesion. And it's a distinct entity from other conditions like a hematoma or I didn't realize like all of these other cholangiomas, cholangioadenomas. And so it's benign, and it's usually subcapsular, like this case was. It was subcapsular in location, and they enhance, and they have persistent enhancement on delayed imaging like cholangio. Prospectively, I would just call it cholangio or something nasty, until proven otherwise. This was I mean, based on at least the literature, it kind of followed what a bile duct adenoma it typically looks like, which is subcapsular location enhances. So that's my case.
Nelly, I have an accompanying story, which is that I was called to the operating room once to look at like this nodule on the surface of the liver.
Yeah.
And it was like a white little nodule. And I was like, I have no idea what that is. Maybe it's a MET. And we sent it off for frozen, and it came back bile duct adenoma.
Oh my.
And then the pathologist was like, we see these like all the time on livers.
No way.
Yeah, but they're usually really small. So and I just looked up this, I just Googled it, and these pathology outlines, it says they're usually like 5 to 15 millimeters. So usually less than 5 millimeters actually. So I think it's like something pathologists see a lot, but that like is below our resolution on imaging. Yours was a huge one. So like, it seems like that would have to be biopsied, but yeah, I didn't even know they existed until I viewed one in the operating room.
That's cool.
May I share my cases?
Yes.
Okay, so this was a 46-year-old female with breast cancer, subsequently found to have PRCA mutation. She had subsequently a total abdominal hysterectomy and bilateral salpingo-oophorectomy prior to this first examination. But this was an exam that was obtained in the ER, and the patient was doing well after her follow-up with her oncologist. So in the ED, an abdomen ultrasound was first performed, and you can see there are at least 2 or 3 intrahepatic lesions. I draw your attention to this larger one. And I wanted to ask the group if you guys had any thoughts about these lesions.
They look kind of ugly to me.
Yes, that's absolutely correct. So this was correctly identified as likely intrahepatic metastasis. And subsequently, the same day, later on in the afternoon or evening, a CT examination was performed. And just before we go to the CT, I just wanted to point out that centrally in the lesion, there are hyperechoic foci that have shadowing, and this represents calcium. So on the CT, again, these lesions were seen, and you're absolutely correct. These are malignant. They are metastatic, but the astute radiologist who looked at this case actually noticed the calcification, thought about a potential GI primary in this patient who previously had breast cancer, and was then able to find a lesion here in the GI tract. And this was subsequently, colonoscopy was performed, and this lesion was biopsied, and it came back as adenocarcinoma. So these are metastatic lesions secondary to colon cancer, to this very invasive colon cancer. I think this was a very good pickup by the radiologist who interpreted this exam, who was then able to, on the same examination, find the primary source of these intrahepatic metastatic lesions. The other case that I wanted to share with the group is also something.
Ben, I have a quick question on that one.
Yes.
That is a great pickup. Do you know if those were mucinous? Like if the colon
they were
cancer
actually,
was mucinous?
that's how the radiologist came to that conclusion. She saw these intrahepatic metastasis, and she thought about a mucinous colon cancer, and she found that lesion that I showed. And it's a subtle lesion that could have been, someone could blow by this and not notice it if they hadn't thought of it. So this was a very, very interesting case. So my next case is a 66-year-old female who was previously doing well, and came in with abnormal LFTs, and this was the initial CT examination that was performed for the patient. And I mean, it's not, it's a fairly obvious finding. The intrahepatic and extrahepatic ducts are very dilated. I was wondering, as I scrolled through, if somebody could tell me what they think the etiology of the bile duct dilation is. For reference, I'm going to put these two. I'm going to put these images. This was actually interpreted as intrahepatic and extrahepatic bile duct dilation, and Kadar is correct. This was a diverticulum. It actually was a duodenal diverticulum that had inspissated material in it. Previous to this, this diverticulum had caused pancreatitis, which was treated conservatively. This was a second follow-up visit. When we were looking at this, we thought maybe some ingested material or a Bezoar type of material or something that got stuck here. Based on our recommendations, subsequently an MRI was performed, and the MRI was also very interesting, and I wanted to share a couple of the sequences here. So again, we have so on the MRI, if I can convince you, the common duct is slightly smaller compared to the CT. It's a little bit differently sized, but when we measured it on the CT, it was about 19 millimeter, and on the MR it was about 14 to 15 millimeter. Interestingly, that diverticulum had decompressed. So whatever stuff got stuck there that gave this patient pancreatitis and dilated bile ducts did eventually move out of there. There's a little bit of air and fluid in here on our exam. But the other interesting thing about this were these foci of restricted diffusion. And so on the MRCP, the left bile duct is dilated. The right bile duct is less conspicuously dilated in the intrahepatic segments. But on the right side, you have all these foci of restricted diffusion, and they had abnormal arterial enhancement. So this was microabscesses secondary to intrahepatic cholangitis. I can show the arterial images to show that a little bit better. So
Ben, I don't know if you see the chat box, but Omar brought up Lamel syndrome.
That's actually on the CT, Lamel syndrome was the diagnosis that was given, and this is the reason I'm sharing the case.
Yeah, it's a Bezor in a diverticulum, and we had a case at Emory, so we love bringing up Lamel syndrome.
Yeah,
but
it's actually the first case of Lamel syndrome that I was seeing. So I wanted to share it with the group, and you can see there's peribiliary hyperenhancement and these foci that represented microabscesses, which have like a little bit of peripheral hyperenhancement in the right hepatic lobe. And again, this was a very interesting case that I wanted to share with the group.
Do you know if they're going to do a Whipple or anything?
This was actually something that we read yesterday evening, so I haven't had enough time to see how they are going to manage this patient. But it was an interesting case, so I saved it to share it with the group.
Cool. And Ben, do you mind saving your last case for next time?
Yes, absolutely, no problem.
Respect the time limit.
We can end on time, no problem.
Thank you so much, Ben. Those were great. Thank you, everyone. Have a good day.
Thank you.
Thank you. Bye-bye.
Thank you.
Great stuff. Thanks.